Afternoon to everybody. Probably good morning to everybody out in the West, but it's delightful to talk to you about something which I'm passionate about, and that is slightly narrower than Chantal mentioned. I'm focusing on measles eradication, and just got back actually from a regional consultation last week in Manila in the Philippines, really looking at the progress that has been made in the region and the lack of progress in terms of measles and rubella elimination. So I'll draw a little bit on that experience. But why am I passionate about measles eradication? Well, if we can get rid of a virus for good, it's an enormous public good. It's the ultimate in equity, because those at greatest risk are often those who are the poorest and most marginalized in our community. So I'll talk a little bit about the feasibility considerations when looking at whether it might be eradicatable. I'll look at the specific challenges when it comes to measles, in particular its reproduction number and a effective reproduction number. And then I'll look at a few epidemiological and demographic challenges as well that will make this job really hard to achieve. So first of all, with the decade of vaccines, there was a lot of excitement, a number of very large donors, particularly Bill and Melinda Gates Foundation, and obviously a whole bunch of others going through Gavi. There was a feeling that the first decade of the 21st century could be a real watershed moment for vaccine-preventable diseases and child health globally. And amongst the various foci, and these included new vaccines, getting old vaccines out to kids that have missed out in the past. But one of the issues was, were there any opportunities for furthering the eradication or elimination of a particular nasty childhood illnesses? And obviously one was limited to those where there were effective vaccines available. And so in 2010, I was privileged to actually chair a technical consultation in Washington, where the whole viability and feasibility of measles eradication was considered. So the first part of this presentation will look at similar considerations to those that we looked at that point in time. The first one that we considered was whether it was biologically feasible. So what was it about the pathogen, about the virus itself, that suggested that eradication was possible? And when I talk about eradication, probably important that we share the same understanding, and really that is the interruption of endemic transmission right across the globe. Elimination is when you achieve similar interruption of transmission, but in a restricted area, for example, a country or a region. But when you get global interruption, that's eradication. So the first consideration is biological feasibility. What is it about the virus that suggests that we could potentially eradicate it? Well, there are four key issues when you think about that. One is that humans are the only host. The minute you have an intermediate host, whether it's a mammal or some other animal, or a reservoir, and that might be even in the environment like polio, where polio can remain viable in feces in the environment for extended periods, it becomes much more challenging. Now with measles, humans are the only known host. Even though we can infect non-human primates, the virus soon dies out. You don't get long-standing chains of transmission. The second important consideration is that measles, with natural infection, you get lifelong immunity. You're protected effectively for life, which is wonderful. And there are very few infections where that is the case. There's only one serotype, and that makes life a whole lot more simple when targeting vaccine development, for example. And then the other thing about measles, which makes it unlike viruses like HIV and influenza, is incredibly genetically stable. So on all of those four counts, measles virus is unique. It is potentially eradicable. And we'll talk, though, about the other part of its biological feasibility that makes it a real challenge is its infectiousness or its reproduction number a little bit later. The second consideration is programmatic feasibility. What is it about the tools that we have available to us that make this a possibility? And here we're really looking at the vaccines and diagnosis. So the measles vaccines, we've got a long track record, one of the longest track records for vaccines beyond maybe rabies vaccine, where we've proven time and time again just how safe and effective measles vaccines are. And despite some of the concerns that were raised around immunological problems and autism and so on, all of the independent reviews and all of the science that has been gathered that's in any way credible and high quality says that these are very safe vaccines and highly effective in promoting individual immunity. They provide long-term protection against all known genotypes, which is fantastic as well. We've got accurate diagnostic tests, and obviously as we get closer and closer to elimination, we are going to get false positive results, both with serology and less likely so with genotyping. But we've got fantastic diagnostic tests that we understand very well. And then very importantly, from a technical feasibility, is demonstration that actually at the time that we had this consultation, there were countries in every region of the globe that had actually effectively eliminated measles. And the Americas, and I'll just show you what had happened in the Americas, and this is the decades from 1980 through to 2010. You can see with the red bars what the measles incidence rates were, incidence, not rates, those were cases, had been, while the black bar is the first dose of measles-containing vaccine was introduced. And unsurprisingly, we've seen this pattern everywhere. As the coverage with vaccine goes up and gets towards about 80 to 90%, measles outbreaks become quite uncommon. They don't disappear. And what we found is that you need really 2 doses of vaccine. And initially in the Americas, they had a single dose in the vaccine schedule at a year, in the first year or second year of life. But then they, to supplement that, they gave a second opportunity. Now, subsequently, that's been included as a second dose of vaccine, either in the second year of life or in some developed countries just before kids go off to school. But in those days, these big SIA, supplementary immunization activities or campaigns, and you can see the catch-up campaigns was really a broad age range campaign, normally from 9 months to 14 years. And then as cohorts, susceptible cohorts after that accumulated, they would do a catch-up, a smaller catch-up campaign up to 3, 4, 5 years of age, every 3, 4, 5 years. You can also see on that slide just what the projection was, how much money would be saved, how many cases of measles would be averted, and how many deaths would be averted through elimination in the Americas, something which has subsequently occurred. And we'll talk a little bit about a hiccup that occurred as well in a moment. The third feasibility criterion was, well, if you've got a virus that lends itself to becoming eradicated and you've got the right tools, can you actually produce enough of the vaccine? And fortunately for measles, there is the possibility. So there is an accurate vaccine market analysis that was conducted. But just to give you a feel, there was really an increase in 0.7 billion doses that was required between 2010 and 2020 beyond the current control and elimination activities. Part of the risk there was that this was concentrated in just a few countries, so the production capacity was concentrated in a few countries and in a couple of manufacturers. And there's been significant investment in extending and expanding that the source base into the future. The fourth consideration is the impact on health systems. So you don't want to damage health systems. And a lot of this concern came from the legacy of polio, where repeated SIs or repeated campaigns saw health systems effectively grind to a halt with all their other service delivery, as in places like northern Nigeria or on the bordering areas of Pakistan and Afghanistan or parts of India before polio was eliminated. The services were just running campaigns. and can be very destructive. Health services generally don't mind. The health workers generally get paid more for running campaigns and doing it over weekends and so on, but it's incredible to routine service provision. And it was realized at that point that in very weak countries with very weak health systems, eradication efforts could be destructive. And so the key would be really to add value. So if you are having to do a campaign, make sure you don't only provide measles vaccine, make sure you combine it with rubella vaccine, make sure you deliver vitamin A or anti-helminths or bed nets or whatever else is the priority in that setting, but really to strengthen the infrastructure so that health infrastructure was built that was a legacy beyond measles elimination. And this is still, I think, a key challenge. Where measles remains endemic are areas particularly where there is limited health infrastructure and weak health infrastructure, and where this has to be strengthened. The fifth consideration was an economic analysis. Was this a good spend of public monies or donor monies? And it's quite extraordinary. This work has now only subsequently been completed, actually in the last 2 or 3 months, by a Kids Risk, Kim Thompson's group, who've done a lot of economic modelling. And really there's probably no better return on investment of health dollar than eliminating or eradicating measles. Kim's analysis showed that the investment case would save indirect treatment costs for measles infections globally more than $2 billion a year, and that the daily costs effectively prevented would be in the order of $63 billion per year saving. And if one delivered a measles vaccine using a combination vaccine with rubella vaccine, there'd be extraordinary additional benefits. And this work has just in part been published, and the full publication will follow very soon. So the economic analysis is pretty compelling, but the equity analysis is also just as important. And this is a statement actually from a colleague of mine in Health Canada, Natasha Crowcroft. And she often says measles is an equity virus. Without vaccination, everyone gets measles, and without equitable healthcare systems to deliver vaccination, measles will continue to present a threat to the most vulnerable. So a very telling statement on equity.
David? You want to?
Hello, are you there?
Yep, that's enough.
Okay, so the sixth important consideration is what happens after measles, and this has been a real worry with polio. Obviously, a virus that can remain in the environment is a real problem, and if that virus is also found in multiple laboratories all around the world, that can be a real issue as well. So what about the post-measles era?
Sorry, David? Are you having troubles with your slide?
Yeah, so what we'll need to do, I think...
There we go.
I think you'll get an email.
Is that better?
Yep, all you have to do is just hit the right arrow when you want to go to the next slide.
Yes, no problem at all.
Yeah, just so it doesn't lose that.
something unfortunately confounded. So the big issue is can measles continue circulating once we interrupt it amongst its human host? And it appears that this is very unlikely. As mentioned earlier, we don't have any non-human primate reservoirs that will keep it going. Persistent and chronic infections, unlike polio in certain immune deficiency conditions, don't exist. Vaccine-derived virus, which has been a major issue with polio, appears to be extremely low if it occurs at all. So the key thing is going to be to have specific controls, containment plans around laboratories to ensure that there is no clandestine release, but probably for at least a decade, particularly in the era that we live with terrorism-focused activities, it will be necessary for a decade or maybe 2 decades to have at least one dose of measles vaccine provided to all receptors, probably at an ideal time, sometime probably school entry age, to get the highest possible seroconversion. The final consideration is really an important one, and that was, what about the political fees? What was the political will for actually tackling eradication? The globe and donors, I must admit, have become reticent, and I think this is a big challenge. They've become reticent about eradicating diseases. There have been 3 attempts globally: smallpox, which worked; polio, which we should have finished in 2000, and we haven't; and malaria, which was the first one that was embarked on, and where after nearly 2 decades of work, it was abandoned officially. So we've got a real issue making sure that there is political will. So the SAGE committee, which informs the Director General, reviewed all of the results of the consultation, and they said it is a worthwhile goal. It can be done and it should be done. But it should be done with appropriate milestones to confirm progress. And it should be garnered as a particularly unique opportunity for actually strengthening routine immunization programs around the world. And while we're going about it, for goodness sake, knock off rubella at the same time, because rubella is a much lower reproduction number and could easily be eradicated, and with it, the terrible threat of congenital rubella syndrome. So measles elimination, or effectively eradication, if you talk about elimination in all regions, was included in the Global Vaccine Action Plan from 2011 to 2020. And unfortunately, those interim targets of 2015 were not reached. So rubella has now been, in 2016, confirmed as eliminated in the region of the Americas, and right at the end of 2016, measles has as well. But we're off track in terms of reaching those elimination goals in 5 WHO regions by the end of the current decade. How have we done? Quite extraordinary, really. If you have a look, this is by year between 2000 and 2014, and these are the estimates of the measles deaths. So your y-axis is the number of measles deaths. And the actual bars, the orange bars, are the deaths averted. These are the model deaths averted per year by measles vaccination. And so the cumulative number of measles deaths averted is reached 17.1 million deaths, which is quite an extraordinary achievement. And it's been achieved largely through increasing vaccine coverage with the first dose of measles vaccine, and introducing a second dose of measles vaccine, which unfortunately isn't achieving as high levels as the first dose. In terms of the report card, if we look at the global level, one region, this was in September 2016, at the end of 2016 September, the Americas were again certified as having interrupted measles virus. That outbreak in the red in Brazil was, Brazil had reintroduction, re-establishment, and more than 12 months of transmission of virus. And sadly, the same happened in our own region in the Western Pacific. You can see the other blotch there, that's Mongolia. Mongolia had interrupted measles transmission for 5 years, and then following the Chinese New Year, had a massive influx of measles viruses, H1 virus, a genotype from China, which found a very susceptible young adult pool. And we believe that it was not through failure of their vaccination system, because they've been extraordinary in reaching cohorts of children for a long time, but possibly, and the laboratory evidence is supporting this, a inferior vaccine that had been imported from Russia, which had provided a partial immune response but not robust immunity. So the green countries in the world are those that have been verified by regional verification commissions to have actually having interrupted measles. You can see the Americas have done a great job. In our region, 6 countries and an area, Macau, the special administrative region of Macau, have interrupted measles transmission for at least 36 months. And in the Europe region, that number is about 20 of the countries have now been verified as well. So significant progress, but a lot of the world remains yellow at the moment. And this is the reason it remains yellow. The number of cases, the estimated number of cases by year are displayed, and the 2 black lines are your coverage with the first measles-containing vaccine dose and a second measles-containing vaccine dose below. And you can see that global coverage has really stagnated at about 85%, 86% for the last 4 or 5 years. And even though the second dose coverage is going much more rapidly, it's only 61% globally at the moment, which is inadequate for measles. Inadequate because measles, and this the second part of the talk, is incredibly infectious, or what we say has an incredible force of infection, or has a very high basic reproduction number. Now, not a reproduction rate. All professors of public health, medicine and epidemiology will have a fit. As you can see on this slide, there are a host of different viruses there, and they have very varying rates. Measles, what we're talking about with the basic reproduction number is that the number of secondary cases that a single infected case would cause in a fully susceptible population that are freely mixing. And for measles on average, that's 18. And now it varies. Some of the studies that have been done have estimated the basic reproduction number for measles at about 8. And others take it well up into the 20s. But basically, it's somewhere in that order of about 18. As you can see, hepatitis C, it's somewhere in the order of 2. So without any intervention, with a freely mixing population and no pre-existing immunity, that's the number of secondary cases you'd expect. For rubella, it's somewhere between 5 and 7. So rubella much less infectious than measles in terms of causing secondary cases. Now, it's very hard to measure directly the basic reproduction number. Occasionally you get wonderful natural experiments, like happened in the Faroe Islands many, many years ago, where an entire generation of people had not been exposed to measles virus. They'd been living in their remoteness, and along came a seafaring vessel, and it had measles on board, and it was able to be wonderfully plotted. And a lot of our initial understanding about measles epidemiology came from that beautiful description of the measles outbreak. But there are ways of actually estimating the basic reproduction number. And this is one way. It basically is the ratio of the average life expectancy minus the average duration of protection, which in the past has generally been about 9 months. That's the protection mum's antibodies cross-placenta are providing to the youngster. And we'll talk a little bit more about that later. The ratio of that number to the age of infection minus the average duration of protection. And that gives you an estimate of the basic reproduction number. And this estimate has been very usefully used, and shows that in places with a very high density of population. So the opportunity for mixing is much greater. So parts of Africa, Lagos, for example, you get a very, very high basic reproduction number. As you can see, the duration of infectiousness, the demographics, the opportunities for transmission are all very important determinants of the basic reproduction number. Now, fortunately, we have a good tool with measles, with the measles vaccine. And so we actually have the more important number, which is the effective reproduction number. And the effective reproduction number, which you could see I played on in the title when I said, is measles eradication realistic, and used the RE, or sometimes it's just the R. The effective reproductive number is really the basic reproduction number discounted by the fraction of the host population that's susceptible. So this is the whole issue of building herd immunity around cases. If you reach a specific threshold of coverage or non-susceptibility, then the virus won't spread and it dies out. And so what you try to do is bring your effective reproduction number below 1, so that on average, fewer than 1 person gets infected from each case, and that's when you head towards elimination or eradication. Obviously, if it remains above 1, and one case leads to many cases or multiple cases, well, that's the opportunity for large outbreaks or epidemics or sustained transmission. So the whole purpose of measles elimination or measles coverage is very, very high coverage. And when you've got a reproduction number, the basic reproduction number of around about 20, well, this little formula says to you, oh bugger, I'm going to have to achieve about 95% coverage, or 95% of the kids in the community, and every cohort in the community, so adults as well, need to be immune for me to make sure that my effective reproduction number drops below 1 and we can eliminate the spread of disease. So extraordinary coverage is required. So we've got a highly effective vaccine, but it's not perfect. No vaccine is perfect, unfortunately, and with measles, they're the typical 3 possible failures. Let's go to the last one first, vaccination failure. Tragedy. Having worked in Papua New Guinea and done immunization reviews, it's really sad when you get into a fridge and the temperature in the fridge is sitting in the high 30s, and the vaccine's been sitting in that fridge because the solar panel was stolen or somebody didn't connect electricity, and children have been coming and they've been vaccinated with an effectively ineffectual vaccine. Now, a lot of work is happening on thermostability and, more importantly, on different administrative techniques, and microarray patches are the future, where you don't need vaccines that are stored in fridges and which are very, very thermostable, and you don't need needles and syringes and trained nurses. These are going to be the critical point to really achieving elimination in my mind. Vaccination failures also, if you jab the vaccine, the antigen, into fatty tissue in the buttock instead of into the muscle, and it's poorly absorbed. Then we go to primary vaccine failure and secondary vaccine failure. And for measles, primary vaccine failure is the bigger challenge. And this is really that conflict between mum's immunity, that wonderful protective immunity that mother transmits to the little one through antibodies, that provide up to 9 months of protection, but also interfere with the response to vaccine. And so measles has always been a trade-off. The ideal timing of the vaccine so that you get the best benefit from mom and you don't have mom's antibodies interfering with the vaccine response is a really tricky business. But it's also the reason that even at 9 months of age, if you jab a child, you're only going to get about 90% seroconversion. If it's 6 months, in the past it was in the order of about 80% seroconversion. So 20% of kids that are vaccinated at 6 months of age are not protected and will need another dose of measles vaccine. And this is where the whole strategy of a second dose, providing a second dose to boost, which at 18 months, 95% seroconversion, boost that up to close to 100% by giving a second dose in the second year of life. So primary vaccine failure is a challenge. Secondary vaccine failure is less of an issue. This is where you get the waning immunity. And often in the cases where we think this has occurred, when you check, you cannot rule out cold chain issues in delivery. So, for example, there was a large outbreak in the Federated States of Micronesia, and the re-establishment in Mongolia probably weren't true secondary vaccine failures, but it is something that can happen, and we're all aware of some people who've got recorded 2 doses of measles vaccine, and during very large-scale outbreaks with lots of transmission in highly congested areas, you may get 1 or 2 of those folks actually developing measles. Usually a very, very mild disease, and secondary transmission from those individuals is rarely, if ever, demonstrated. So, ideally, if we had perfect registration systems, we'd be able to quite accurately determine what our immunity levels are. But I'm putting up this interesting slide from Malaysia, which, as you can see, is well dotted because measles is still endemic in Malaysia, just to show you some of the real problems with administrative data. This is not a specific criticism of Malaysia. This is just one example and something that we see around the world. So there's a reported coverage in that last column of 96.61% in the birth cohort, in the latest birth cohort at 1 year of age. But as you can see, incredible variation stemming from 78%, which is very worrying because obviously that's not providing adequate coverage and immunity in the population to create herd immunity, so there's going to be opportunities for susceptibles to accumulate and to feed an epidemic. But then equally worrying are coverage rates of 106% and 104%, because that says one of 2 things. Either the systems aren't accurate in capturing the numerator, or the systems aren't accurate in terms of a denominator. So how many people really are at risk? And so this is the real issue in many parts of the world where really the data are inaccurate, either denominator or numerator data. So we've got this wonderful tool, and I'd strongly recommend those of you interested in disease dynamics, infectious disease dynamics. If you haven't read Nigel Gay's paper, which was published in the Journal of Infectious Diseases in 2004. It's a fantastic read. And what he does is Nigel Gay and his collaborators actually demonstrate how you can estimate the effective reproductive number from data sets from outbreaks, effectively, in countries where the administrative systems aren't so strong. And so what you see at the bottom there is your effective reproduction number, and a distribution of outbreaks along the y-axis. So if all of your outbreaks have only 1 case, well, they all die out, so your reproduction number is 0. On the other hand, if your reproduction number down on the right-hand side of that figure is 1, you can see that although some cases, about 40% will only have 1, outbreaks will have only 1 case, there'll be outbreaks with large-scale outbreaks with up to 100+ cases. And it's that distribution of those outbreak sizes that allows you to estimate your effective reproductive number. In the same article, Nigel Gay and other people, I think Mark Papania was on that as well, the number of generations of spread, the distribution of the number of generations of spread of outbreaks in a particular setting or country is equally informative in estimating the reproductive number. So you can get a very good feel as to how vulnerable you are to outbreaks and how far you are away from elimination by really carefully analyzing the size and the duration and the number of generations of spread of your measles outbreaks. And outbreaks, when it comes to measles, outbreaks are incredibly informative and worth focusing on very, very carefully. They also tell you who's getting measles, and that points to where the immunity gaps are, but again, across a series of outbreaks. So I'd strongly recommend that. Nigel Gay uses a third measure, which is the proportion of cases that are imported cases as well. But when you triangulate the 3, you actually get a pretty darn good measure of the effective reproduction number. Now, let's put reproduction numbers aside and look at the other challenges that are emerging when it comes to measles epidemiology in terms of achieving these elimination and eradication goals. So this is a paper that's just been published by Matt Ferrari and colleagues, and Matt Ferrari is probably the leading infectious diseases modeler working on measles in the world at the moment. And he has raised real concerns about how sustainable the campaigns, these SIAs, are as the second dose. So achieving that first dose coverage, but then adding a supplementary immunization activity or campaign to keep your effective reproduction number really, really low. The problem that he found is the modeling, when they took real data and they modeled it, you can, for a period, you can keep pushing your effective reproduction number below 1, but eventually your SIAs find you out because you continue to accumulate susceptibles. And the problem with SIAs is that you often end up catching the easy fruit to pick. And I mean, some of these are achieving wonderful 90% coverage, but it's the same 90%. And so the 10% that are migrants or nomadic or up in the mountains, yes, maybe you don't always get outbreaks there and they might burn themselves out because you need a critical population to keep them going. But in some of these bordering areas in the Mekong Delta, for example, there are large populations that move continually across border areas and which are large enough to sustain large outbreaks. And this is what we've seen in Vietnam, Cambodia, and places like that. And Matt shows that from a mathematical perspective, we're going to have to do a lot better in getting 2 routine doses in that are well-timed and benefit all children, get the doses into all kids everywhere in order to achieve and sustain measles elimination. This is a particularly interesting, this is work that was done by Fook and his group in the UK, in London, and they looked at the challenge of heterogeneity in age mixing. So a lot of these models have talked about effectively freely moving populations, but not subsets of populations. And he took some real data using sero-survey results and actual outbreak results from a whole host of countries, some in Europe and some in Africa and some in the Western Pacific. And he showed that at the moment, their effective reproduction numbers appear to be below 1. And so they should be able to sustain elimination, except for Uganda. So Uganda's reproduction number was above that. But once you actually looked at mixing patterns, so once you actually took the social science and what was known about the demographics and the movements and the contact between groups, particularly young adults and young children, which is unsurprising because young adults have young children and they mix with young children, the picture changes completely. And so the granularity of including age-specific mixing rates in understanding of the transmission dynamics of disease has become much more important. So a very nice paper, or actually not yet published, this was shared with the SAGE Working Group of Measles and Rubella, but will be published by Fuchs et al. Hopefully later this year. What he also looked at, which is fascinating, is the top, if you have a look at the top of that figure, those are the current coverage as was predicted would be required by in the initial modelling that was done. And I think it was Liz Miller at Public Health England, or in those days was the NHS who did that modelling. And if you look at A, that is the current status, and again he's used the same countries. If you fill the gap, which is B, in the 0 to 4 age group, it has very little impact at all. So you move from 85% to 90%, you achieve very little. The model says that the place to really make an impact is the 5 to 9 year age group. So if you can close the gap there between 90 and 95%, that's the best win in terms of any 5% at any age group, either losing them or adding them across the age demographic once you take age mixing profiles into account. And this is really interesting because for a long time, my colleagues in the United States have said the only reason they ever achieved measles elimination in the United States was they don't have the coverage we have in Australia, was the school entry check. And the fact that they put that barrier in place appears to be critical, and it looks like the modelling data supports the importance of getting higher coverage in that age group, which is the young preschool age kids. Not the very youngest, but those that are just entering school age, because obviously, if we think about it, schools provide a marvellous opportunity for measles to find any immunity gaps. So some very interesting modelling work that is showing how important that particular age group is. Then to China. So China is one of those countries which poses particular challenges just demographically in terms of measles elimination. China has had, and I should have shown you a much longer time series, but has done an incredible job in controlling measles and achieving very high across the country in its birth cohort, so with a single dose of measles-containing vaccine. China has introduced a second dose of measles-containing vaccine. They currently vaccinated 8 months, which isn't ideal, but may become ideal if the data from China and Italy and other places, which shows that women who've been vaccinated and haven't had wild viral disease probably provide antibody protection to their little ones, their babies, for slightly shorter periods. So maybe the 8 months isn't too bad in China. But as you can see, China has continued to have these epidemic spikes every year. In 2010, when a very large spike was predicted in 2011, China embarked on probably one of the great public health coordinated actions ever. And in 1 month, 102 million children were vaccinated across China. Now, every province, all of 31 provinces, achieved extremely high coverage, at least in the 8 months to 5 year group. But in half the provinces, they extended it up to under 15-year-olds. So they absolutely dampened measles transmission down. As you can see, the impact in 2011 was amazing, and then even more amazing into 2012. And that's exactly what the model said would happen. The problem in China is, look, it didn't sustain. So even keeping single-dose vaccine going at very high coverage, 2013 up 2014, you're back to your pre-massive campaign levels. So quite extraordinary. And now we're seeing the fact that, yes, they found a lot of the susceptibles, and so we're seeing small outbreaks. But 2017, and China's really worried, 2017, 2018, the possibility for a very, very large outbreak. And they're looking at some very large-scale, province-specific activities now to actually try and close that immunity gap. But what problem is China facing, which is the problem that Australia is facing, but on a much smaller scale, is where are these cases now occurring? And unsurprisingly, many of them are in the age group that are too young to be vaccinated, 38% in China. But in the past, that was the vast majority. 20% of them occur up to the age of 15 years. Not many, because they've had very high coverage. But the legacies, the sins of the fathers in measles catch up with you eventually. So because China, like Australia, like New Zealand, slowly built its coverage, we've got these cohorts in the 15 to 30 year age groups that are poorly immune. There are immunity gaps, and we've got an outbreak at the moment in Western Sydney, which is finding those immunity gaps in older teens and young adults. And this is the problem of poorly performing immunization programs historically. Effectively, they push the susceptibles up until you get enough of them cohorting together to actually sustain outbreaks. And that becomes a huge challenge. And becomes very challenging, and as we've seen in Australia, when the big national catch-up campaigns were done, which group did we fail to reach very well? Those folks who had left school. So once they're still in school, we can reach them, but the minute they leave school, it becomes a challenge. And this is not only what China's seeing, it's what we're seeing, it's what we're seeing across the European region as well. The further interesting thing from China is that it's not homogeneous. So the eastern provinces in China are very much more like Australia and like the US and very developed. And they're on that right-hand side of the bottom graphic. So they may not be seeing very high case numbers, but their case numbers at the moment are predominantly amongst adults. If you go right to the western side of China, you'll see that that has very much more the profile of endemic areas, and those are areas where their coverage is less substantial and where you're getting the traditional age groups affected. So China, a single approach in China will no longer work. It has to be tailored to the various provinces. The other problem in China is for a long time we've known about the importance of nosocomial measles transmission, where sick kids end up taking it into hospitals. Our GP practices, unfortunately, don't have ideal infection control all the time. And so what happens is you get these outbreaks that result, and we've seen this in Australia as well, and most recently in Sydney, Western Sydney a couple of years ago. But the big drivers in China, and this is a paper that has been accepted for publication by a group from the China CDC, which has a look at what are the drivers, what are the biggest differences in the 300 largest cities in China in terms of their measles transmission. And the single factors that were most important in driving measles outbreaks in China were, not surprisingly, the population being an important contributor, but it was the proportion of the population that was 15 to 64 years of age. It was the working age group, and it was the migrants, both those moving between provinces and those moving within provinces. And this poses a real challenge, is the movement of people from areas where maybe coverage is been less robust in the past into highly congested, very dense populations makes the measles challenge much greater. And it means, and China's thinking about this now, how do you then restructure your target groups for vaccination? You've got to target migrant workers. Well, how do you do that? Well, maybe you can work that into occupational requirements and so on. So a lot of that thinking is happening at the moment in China, and it needs to happen in other areas. The B3 outbreak of measles that basically exploded in the Philippines, and then from the Philippines exploded globally, because Filipino workers are sought after the world over. They're in all sorts of industries, and that's just how it exploded. Now, if there had been some thinking about migrancy, I mean, probably the best described outbreak I've read up in recent years was one published amongst the Amish community and published this year in the New England Journal of Medicine. Fantastic. If you want to read an excellent outbreak description, that's the one to read. But that was totally predictable. So these wonderful folks, Amish aren't anti-vaccination, but they don't promote it. They went over to respond to these after the cyclone. There was a measles outbreak on the go. They brought measles back, and it spread like wildfire in the Amish community. That could have been prevented by actually just promoting amongst the aid workers and development workers vaccination. So we need to become a little bit cleverer in how we target high-risk groups. And in Australia, the challenging group is young adults that are travelling to Bali and Thailand and so on. And how do we really reach those groups as well? So some additional epidemiological challenges. These immunity gaps. How do we better define immunity gaps? And here's where outbreaks are a wonderful tool. They're our best teacher. And if we take not a single outbreak, but take the patterns of outbreaks, then we can target better where the immunity gaps are. Measles poses an interesting challenge, obviously, before the rash erupts, and it's obvious clinically, except, of course, it's not that obvious to GPs who no longer see the disease, but it should be obvious clinically for 4 days before that a person is infectious. I've mentioned nosocomial transmission, high vulnerable groups around a case that isn't adequately quarantined, isolated. Maternal immunity, we mentioned briefly the fact that it appears that this is now less robust with vaccine virus, and whether the 9-month opportunity in most of the world or the 12 months if we use in Australia is ideal in terms of timing is open to question and debate. And we've talked extensively about the legacy effect of poor historical immunisation program performance. There are a few other fascinating things when it comes to this disease. If you ever want to really brush up on your infectious disease epidemiology, measles is a fantastic example. And I was fortunate enough to work with Natasha Crowcroft and Peter Strebel, who headed up the measles program for the WHO, just looking at some of the things that we can learn from the epidemiology of measles. And I provided the link. It's an open access article that was published in Vaccine, a review article about what we can, as we edge towards elimination, what can measles, the epidemiology of measles teach us. And some of the things that we covered were the value of the epidemic curves, how critical understanding the source of infection is, and if your surveillance system isn't able to detect the source, in most cases,